What's the evidence in 2018 for the use of platelet rich plasma in the upper extremity and some other areas too? So I guess I'll introduce myself. I went to do my undergraduate degree at the University of Pennsylvania and then went on to medical school at Case Western. I am originally from Ohio. And then I did much like Dr. Christie, my plastic surgery training at Mount Sinai, and then did a fellowship in hand and microsurgery at UCLA, and then came back here to practice. I have no personal disclosures. So I'm going to go over a little bit of what is PRP, as far as we know, what's its mechanism of action, what are the indications for its use today, what are the outcomes of evidence for its efficacy in 2018, and what direction are we going in the future with it. So what is PRP therapy? Well, it's a non-surgical injectable treatment. It's been used across many specialties, across sports medicine, across orthopedics and hand surgery, and also in plastic surgery for issues such as hair growth or skin rejuvenation. Basically, the PRP solution is injected into whatever affected area you're talking about. The idea is to stimulate and enhance the body's natural healing, and it is an autologous blood product. Basically, we're giving mega doses of the body's own healing ingredients, basically growth factors that are stored in platelets, and allowing the body to sort of regenerate itself. Obviously, if you look anywhere on the internet, PRP is everywhere. Lots of different specialties are offering it. They're touting it, as the next thing since the next coming and the greatest thing since sliced bread. But we're not, I don't know that the evidence is there yet, and we'll get into it. So what is it for real? It's an autologous blood concentrate. It contains supraphysiologic concentrations of platelets. So in order to be considered PRP, it has to be a minimum of 4 to 5 times the normal platelet count per the injected. It's regarded as a minimally manipulated autologous blood product by the FDA. And why that's important is because the PRP itself has not undergone the rigorous testing as you would say for a drug that needs FDA approval. Already there isn't much restriction as to its use by physicians or anyone else. And then we don't know what the optimal concentration of platelets are to be. We do know it has to be at least 4 to 5 times normal. We don't know what's the best yet. Essentially, patient comes in, their blood is drawn in the office, 30 to 60 mLs of autologous blood. It's centrifuged in order to separate the different components of the blood. And there's a lot of different commercial systems available and a variety of preparations that are available. And then it's either directly injected into the area or applied as a topical spray. So essentially, when you centrifuge the blood, it separates into its 3 layers. So you've got the red blood cells at the bottom layer, which are heavier. Then you've got the platelet poor plasma, which is the larger top layer. And then the sweet spot is in the middle. It's the platelet concentrate. This is the smaller middle layer is what we're interested in. And there's different formulations that can be used. There's both a leukocyte rich and leukocyte poor. Essentially, the leukocyte rich contains a higher concentrate of the white cells, which is actually has about the same weight as the platelets. So initially the formulations are leukocyte rich. It's got a higher concentration of certain pro-inflammatory cytokines. It might increase angiogenesis. It does have some role in inhibiting bacterial growth, but it does create an exaggerated inflammatory response to the area that's injected. And then there's a leukocyte poor preparation where the white cells are washed out, and then this may be suitable for certain indications such as intra-articular injection. And then there's activated versus not activated. Essentially, the activated formulations, they're pre-treated with calcium chloride plus or minus thrombin, and this causes the release of the cytokines immediately from the platelet granules. Non-active formulations actually require it's the contact with the intrinsic collagen in the area it's injected that causes the activation. But one thing that's constant is that you have to use it right away. It's not something that can be stored because 70% of the growth factors are released within 10 minutes of activation and then 100% within an hour. So you're getting a fairly immediate effect with whatever you're using. And then just a little platelet anatomy physiology. Platelets contain 2 types of granules. They're your alpha granules, which contain most of what we're looking for, the hemostatic properties, the growth factors, cytokines, chemokines, adhesion proteins. And then there's your dense granules that are important for promoting platelet aggregation. And so when I say the basic science behind it, and this is really only theory, we're not really sure how it works, but we think that it's enhanced healing from this direct delivery of concentrated growth factors and inflammatory modulators that occurs, and we think it's platelet-derived growth factor, TGF-beta, VEGF, all the different IL-1 all down the line. We think they were just blasting the area with all this, which really ramps up the body's own healing properties. There's been a lot of bench research into this. So in vitro studies have shown, stimulates chondrocytes, stimulates synoviocytes, and you get improved chondrocyte viability. So there is some, at least laboratory evidence that it does help cartilage growth, increases type 2 collagen, increases mesenchymal cell differentiation, so stem cell differentiation, improves angiogenesis, also can improve tendon and bone healing. These are all laboratory studies, but the in vivo evidence or the evidence in actual clinical practice has been a little bit conflicting.